Okay, good. Right. Good afternoon. On behalf of the UK Kidney Association, let me welcome you to this webinar, which is on a clinical update in ADPKD. So my name is Albert Ong, and I'm an academic nephrologist at Sheffield. We have a very interesting session this afternoon from 4 speakers who will address, I think, very relevant topics in the field at the moment. So just some housekeeping rules. Firstly, just to say that I've been informed that there is RCP approval for CME points. So if you do stay till the end, you are entitled to apply for 2 CME points. There is a feedback form to fill after the Q&A session, and Sarah will say a little bit more about that at the end. Secondly, each speaker will speak for 12 to 15 minutes, I will let them know if they're overrunning, and if it's overrunning beyond 15 minutes, then clearly we will proceed to the next speaker. At the end, we will have 30 minutes of Q&A, and I'd like to encourage everyone to take part in that. Please put your questions in the Q&A box rather than the chat box, and you can specify whether that's to be seen by everyone attending or just by the panelists. I hope that we will have a really interesting session today, but do ask those difficult questions, or those questions you really wanted to ask but have never had a chance to do so. Great. So without further ado, let me introduce our first speaker, who is Dr. Jiehan Chong, who is currently an MRC clinical training fellow at Leeds, having previously been an academic clinical fellow at Sheffield. So Jiehan is going to address the relevant topic of Tolvaptan usage in the UK, and share some information about the Renal Association survey that was done about 2 years ago, and to survey practice across the UK, what we've learned from that, and also share something about local practice in Sheffield. Jiehan, could I invite you to share your slides and show yourself? Thank you. Okay.
And here we go.
Great.
All right. Afternoon, everyone, and thanks for attending this webinar. I'm Jiehan Chong, a clinical research training fellow. And today I'd like to talk about how we're using Tolvaptan in the UK and how we use it locally in Sheffield, and also how we might improve the way we use it in the future. Now, Tolvaptan was approved for PKD by NICE in late 2015. And since then, its use has exploded year on year. From this, I think we can conclude that current Tolvaptan use is likely to be driven almost entirely by PKD. This use, however, is not uniform. And if you look at the distribution across England, the regions using the most Tolvaptan seem to use 6 times as much as the regions using the least Tolvaptan per capita. What could be the reasons for this variation? Are there simply huge clusters of PKD in London, Cumbria, and Manchester? Or might differences in local practice be contributing to this? In 2018, about 2.5 years after the initial NICE approval, we conducted a survey of Tolvaptan use across the UK. This was delivered through the Renal Clinical Directors Forum, and out of 77 main UK units, we received 41 responses. The headline question was, do you use Tolvaptan for PKD? And the vast majority answered yes. Of those that weren't using it at the time, the reasons cited included a lack of suitable patients, the side effect profile, and concerns about sustained benefit. We also asked units approximately how many patients were eligible for Tolvaptan at their unit, And the responses to this varied hugely from less than 50 to more than 200. We also asked about the proportion of eligible patients who were on treatment and about the proportion who had stopped treatment. And the responses to these questions were similarly variable. For patients who had stopped treatment, nearly all were reported to be due to intolerance or compliance issues, and only 2 cases of deranged LFTs were reported in this survey. To try and understand what might be driving differences in local practice, we asked how many people were using the Renal Association commentary on the NICE guidance. And again, here the majority said yes, although a significant minority did not. The reasons cited for this included use of alternative guidance or an inability to measure MRI-TKV. Most units appear to use some kind of MDT to deliver Tolvaptan, with less than a quarter of units having a team comprised of doctors only. There's a range of different ways you can assess people for Tolvaptan, and we wanted to know what people are using. Unsurprisingly, all renal units are using eGFR to assess their patients, and a majority seem to be using ultrasound. Half of the units who responded seem to have access to MRI, and about a fifth of them are using genotype in their pre-treatment assessment. We had a free text question asking how people were monitoring people after treatment, and the most commonly cited modality was eGFR. Of course, LFTs are being checked as well for safety reasons, and 3 units responded that they use ultrasound in their post-treatment monitoring. We asked respondents how they felt the guidelines could be improved. Responses included addressing renal pain, but unfortunately this isn't part of the current NICE approval. There's also comments about more emphasis on ultrasound, but I don't think there's been any development in the evidence over the last years that might justify a change in this. Interestingly, several respondents mentioned addressing patients over the age of 55 and prescribing without access to MRI. In fact, these groups are effectively already covered by the current version of the commentary because there's no upper age limit on Tolvaptan prescribing, and there are channels for assessment which involve just eGFR, which from the survey responses, it appears at least half of units are using without MRI. So I did wonder whether there was some scope for clarifying the current commentary to make it more user-friendly. Overall from the survey, we can see that Tolvaptan and the Renal Association guidance are both widely used, but we do know that there is wide regional variation in Tolvaptan use. And given the responses to the variation in responses to the survey, I wondered if these regional differences might be contributed to by differences in how people are identifying candidates, the rate at which their patients decline treatment, and differences in stopping treatment, potentially due to differences in how side effects are being managed. MDT delivery appears to be widespread, and eGFR is the commonest way people are assessed for treatment as well as monitored on treatment. So that's what I know about the UK. What have we been doing here in Sheffield? In Sheffield, we have a screening program where I use an automated script to look through every single PKD patient we have who's not on RRT, and we have over 300 of these in Sheffield. Each time, it analyzes their eGFR, works out their rate of decline, and identifies suitable candidates. It excludes patients who have CKD1 because we're in England where they're not eligible. We then manually curate the candidate list, and we check the eGFR graphs to make sure there aren't any anomalies. And for borderline cases, we do an MRI-TKV. After this process, any candidates remaining on the screening list are contacted to discuss coming to the clinic, and we repeat this entire process every 6 months. Through this process, in our first year, we recruited a relatively large number of patients, 24. And I think this number probably reflects the point prevalence of Tolvaptan candidates in our catchment area. In subsequent years, we recruited lower numbers, and I think this probably reflects the annual incidence of new Tolvaptan candidates. The reason for low numbers in 2020 is, of course, the COVID pandemic, which caused a halt to our recruitment. Patients in our clinic have their 24-hour urine monitored on a monthly basis during the titration period. And we also do spot urine osmolality and liver function tests every month for the first 18 months. In addition to these, we also do MRI, TKV, and genetic testing as standard because we wanted to try and understand whether these modalities had anything to add in a cohort that's already selected for rapid eGFR decline. We find that the 24-hour urines are most useful for the urine volume, which helps patients understand just how much fluid they need to drink in order to keep up with the apheresis. The mean volume of urine passed per 24 hours is 7.4 liters, with most patients clustering between 6.5 and 8 liters. And this doesn't appear to be hugely different between the different doses that patients have achieved by the end of the titration period. We mainly use the spot osmolalities to try and identify problems with patient compliance. In this cohort, the mean osmolality by the end of dose titration was 185 milliosmoles per kilo, and there weren't any significant differences between the dose groups in this measurement. In this graph here, I've plotted on the x-axis the initial TKV, so at the start of treatment. And on the y-axis, I've plotted the percentage change in their rate of decline 2 years after starting treatment. So if you have a positive, so greater than 0 change in the rate of decline, this means that your decline's actually gotten faster. This is bad, so it's in a red box. And if you have a negative negative change, that means that your rate of decline has reduced, so this is good. And so the lower your point is on the y-axis, the better off you are in terms of treatment response, and the higher you are, the worse. And this graph suggests to us that the higher your initial TKV, the worse your treatment response. This isn't a huge surprise because we know that TKV is associated with disease progression, and patients with more advanced disease do have a worse response to Tolvaptan. The same patients are shown on this graph, except on the x-axis, I put their initial eGFR, and you can see that the relationship is mirrored here with a lower initial eGFR being associated with a worse treatment response. Again, emphasizing that I think it's the degree of disease progression that's playing a role in the disease response here, in the treatment response here. In this cohort, which is almost entirely selected by eGFR decline, in fact, we have only one patient who was selected by MRI-TKV, you wind up with a cohort that's greatly enriched for the worst Mayo classes of 1, C, D, and E. Interestingly, you don't see the same relationship with genetics. Although on this graph, you can see that a higher pro-PKD score is associated with a worse pre-treatment rate of decline. When you look at the breakdown of pro-PKD scores in our cohort, in fact, more than half of our patients seem to have a pro-PKD score less than 6, which would be below the cutoff for treatment if we were assessing purely by pro-PKD score. I think what this may reflect is some subjectivity in patients recalling when their symptoms first started, which is one of the components of the pro-PKD score. And from a practical perspective, I think it suggests that some caution needs to be exercised if you're only assessing people with a pro-PKD. Looking at treatment cessation, over a 3-year period, we commenced 43 patients on Tolvaptan. In the first year, 32% of patients stopped treatment, which is a bit higher than the 24% cited in the TEMPO trials. Interestingly, over the entire 3-year period, more than half of our patients wound up stopping Tolvaptan, which is substantially higher than what's been seen in the trials, and is at the upper end of what units reported in the survey, which was about 2 years after Tolvaptan was first approved. As you can see in this graph, a significant number of patients stopped treatment in the first year, as shown here, but then there's a pretty steady rate of attrition all the way up to 3.5 years, which we have data for. Looking at the reasons for stopping treatment, the majority of patients stopped due to aquaretic symptoms, but in this cohort, we had 4 out of 43 patients stopping due to hepatotoxicity, which represents a rate of 9%, slightly higher than what was reported in the trials. Interestingly, if you break down the time to discontinuation by the reason for stopping, you can see that it can take patients several years to decide that the aquaretic symptoms are too much for them to handle. Importantly, looking at hepatotoxicity, people can wind up stopping from hepatotoxicity all the way up to 18 months, which emphasizes the importance of continuing to check this for the full 18-month period. Looking at treatment response, we have 21 patients in total who took Tolvaptan for more than a year. And out of these, 8 of them were initially non-responders, which I've defined as people whose rate of eGFR decline had increased rather than decreasing by the end of the first year. However, out of these 8 initial non-responders, half of them wind up with a positive response by the end of the second year. Out of the persistent non-responders who continued to non-respond at the end of second year, 3 out of 4 stopped in the third year due to aquaretic symptoms, and only 1 out of 4 wound up progressing to an eGFR less than 15. I think what this tells us is that if you are assessing people for change in rate of eGFR decline, 1 year is probably too soon to do it, because even if you find people with no response at 1 year, half of them turn positive by the end of year 2. But it may be worth doing the check in year 2 in order to avoid the outcome where people keep on progressing at a faster rate than they otherwise might have. How do I think the guidelines might be improved given what I've shown here? Well, first, I think the basic structure of the current commentary is sound, but a visual reconfiguration like this might be helpful to help emphasize that there is a limb where you can assess people using just eGFR decline. I've removed a few of the redundant branches in the existing algorithm which didn't lead anywhere specific. And to the absolute TKV criteria, I think that an age qualifier should be added in order to match up with the inclusion criteria for the Tempo 3-4 trial, which is what this absolute cutoff is based on. Also, given our pro-PKD data, I think that for patients with a pro-PKD score of less than 6, you should consider alternative ways of assessing them. In summary, Tolvaptan use is highly variable across England, and our survey suggests that there may be differences in uptake and discontinuation driving this variation. Also, eGFR appears to be the main way by which people are being assessed for treatment and monitored afterwards. I think our clinic data suggests that urine osmolality and volume can be useful for compliance monitoring. And in a cohort that's already been selected for rapid eGFR decline, MRI and genotype don't seem to add a lot to your management. 1 year is probably too soon to reassess the rate of eGFR decline, because whatever result you find at 1 year, it's liable to change at year 2. I propose a few simplifications to the current commentary, and I'd be grateful for any feedback. I'd like to thank Professor Ong, Tess Harris, Katie Vinen, and the clinical directors, all of whom have helped with the survey on Tolvaptan use. Dr. Matt Gittis is one of the ACFs here in Sheffield, and he helped me get hold of the Tolvaptan variation data. And finally, Dr. Rod Sims is one of our consultants, and Jan McCormick is a nurse specialist who helped set up the Tolvaptan clinic and gather some of the data that I've analyzed. I'd also like to thank the MRC, who currently pay my salary. Thank you.
Thank you, Jiehan, for getting us to an excellent start. Probably lots of questions that people have, so put them in the chat for discussion later. So our next speaker is Dr. Jackie Cook, who I've worked with for many years and who is a consultant in clinical genetics at Sheffield. She's currently interim clinical director for the North East and Yorkshire genome medicine service, and among so many roles. And Jackie's going to tell us about how genetic testing in ADPKD is changing, and how you go about getting tested for your patients. So Jackie, over to you.
Okay, thank you. So this is going to be a mixture of slides and some demonstration of the forms. So could I have the next slide, please? Okay, so my title is Who, When and How to Do Genetic Testing for PKD. So starting off with the who and the when. For the last couple of years, genetic testing in England has been directed by something called the National Genomic Test Directory, which has been put together by NHS England. And that directory says exactly what you can do genetic testing for, and gives clinical indications for that testing, and also says who can order those tests. So if we go on to the next slide, this is the clinical indication for ordering genetic testing for renal cystic disease. You notice it's got an R number, R193. Each clinical indication in the testing directory has an R number, and I'll come back to that because it is something that you need to remember. So the testing criteria currently for testing in cystic renal disease, there are 4 criteria. The first is for patients who have got non-syndromic cystic renal disease and that are atypical, so they are not clinically characteristic of ADPKD. So by non-syndromic, that would take out conditions such as tuberous sclerosis. A syndrome is associated with renal cysts or something like orofacial digital syndrome type 1. These are tested in a different way using panels of genes that are there for congenital malformation and dysmorphic syndromes. So this is just isolated renal cystic disease, and in particular those that are atypical. So these might be cases where people are presenting with small numbers of cysts in both kidneys, or an unusual distribution of cysts, and it's really not clear whether they have autosomal dominant PKD or some other type of polycystic kidney disease due to some of the more recently identified genes. So that's the first criteria, is that atypical presentation of cystic disease. The next is the group of patients that are presenting with symptomatic polycystic disease at young ages. So these are the children. Now some of these will have ADPKD, but a significant number of them are going to have some of these new genes that are being identified, such as HNF1 beta, or some of them that may have a kind of later presentation of autosomal recessive PKD. And then the final group, where at the moment genetic testing is indicated, is where a genetic diagnosis is required to influence management. And I'll come on to some examples of where that might be the case. So as I've said before, those are the criteria for non-syndromic cystic disease. If there is a syndrome, then you would need to have a look at the directory and just see if there is a gene panel or a gene test that is more appropriate for the diagnosis that you think it's probably going to be. Who can request? So nowadays, testing for renal cystic disease is limited to either nephrology or to clinical genetics, to try and make sure that appropriate people are being tested, and it is not just done by anybody because I think it might be interesting to know. And when do you do it? Either at presentation or when a clinical management decision is needed, and that's going to depend upon the molecular diagnosis. Next slide, please. So what about this group where you've got a clear diagnosis? So these are not atypical cases of ADPKD. These are cases where you're pretty certain that that is the correct diagnosis. In that group, when would a molecular genetic diagnosis be helpful to influence management? So at the moment, I think they fall into quite a small number of categories. There's, first of all, those families where live-related transplant is being considered, and where you want to make sure that the donor who's giving the kidney has not got PKD, and further down the line, the transplanted kidney is going to start developing cystic disease. And so what we would suggest nowadays in those situations is that a diagnostic test is done on the affected individual to identify the gene and the mutation, and then the donor undergoes predictive testing for that particular mutation to make absolutely certain that they have not got the condition and are just presenting late. Another situation in where we might consider a molecular diagnosis, genetic diagnosis, we would need to have that, is in families who are considering pre-implantation genetic diagnosis, or PGD. So actually most families with polycystic kidney disease don't choose to have any testing either during a pregnancy or before a pregnancy. But there is a small and possibly slowly growing number of families that make the decision that this is not something that they want to take any risks about passing on, but nor do they want to consider termination of pregnancy. And that's where pre-implantation genetic diagnosis comes in, which is when we use IVF technology to identify the embryos that are unaffected and just implant one of those back in the womb. And then the third, and now following Jiehan's talk, I'm beginning to wonder whether that's correct or not anymore, is it has been used to make treatment decisions about prioritising patients for Tolvaptan treatment in order to find the individuals who've got the truncating PKD1 mutations. So it's a fairly small group at the moment, and then there is an argument about whether actually we should be testing everybody with autosomal dominant PKD, and are we at the point where that would be recommended? I think the answer to that is still no. It is quite clear that a renal ultrasound is still an extremely good way of diagnosing PKD in adults, and is considerably cheaper than a whole genome sequence, and is considerably easier to interpret than a whole genome sequence or a molecular diagnosis for PKD1. So I think we're not quite there yet. Is there a situation in the future where we might be? And I think certainly if we get to the point where treatments are developed that need, in order to work and to be of maximum benefit, need to be commenced prior to the development of cysts, then we get into the area where we need to be identifying children with PKD before they start to develop those cysts. And the only way to do that will be on molecular genetic testing. I think we're in a sort of halfway situation at the moment, and certainly in Sheffield it's becoming clear that there is quite a big discrepancy between what the adult nephrologists are advising families, which is to screen in late teenage years to start to identify the affected family members, and what the paediatric nephrologists are suggesting, which is to use genetic testing to identify the gene mutation in the family and testing the children at a younger age, mainly at this point in order to avoid unnecessary follow-up of the unaffected children. And I think this is something that we're going to have to, I think, start to develop some protocols and guidelines about what exactly we're going to do with this slightly different approach between paediatric and adult nephrology. Next slide, please. So how do you do genetic testing for PKD nowadays? So a year ago, I would have been giving this talk and I'd be talking to you about next generation sequencing. Now it has moved on to whole genome sequencing. So before I go into detail about how you order a whole genome sequence, I just want to clarify what exactly whole genome sequencing is. So altogether, we have about 20,000 protein coding genes, and that makes up about 1% of our genome. So 99% of our genome consists of a whole load of other things, most of which we haven't got a clue what it does. there are various ways of looking at genes. So we can look at single genes, we can look at gene panels, which is usually a small number of genes that cause the same clinical phenotype. We can do whole exome sequencing, which just looks at the protein coding regions, so that 1% of our total genome. Or we can do whole genome sequencing, which looks at all the coding and non-coding sequences. And using whole genome sequencing, the diagnostic yield from that for all conditions which we believe might be genetic is about 20 to 30%. Next slide, please. But there are a few things that I need to probably make clear about whole genome sequencing. So first of all, indeed, the whole genome is sequenced, and that data is all stored electronically. However, it's a bit of a misnomer because the whole genome is not analysed. Two main reasons for that. First is that, for a start, we don't know what the vast majority of it does, so an analysis of it will not get us any further forward. But the main reason is because of the huge amount of genetic variation that exists between individuals. So we all carry about 3 to 4 million variants within our genes. Now, the more genes you sequence and analyze, the more variants that you're going to pick up, until you get to a point where you're going to spend years trying to sort out the variants and never get to the actual cause. Therefore, we do use gene panels to analyze. So we use large gene panels that consist of all the known genes for a particular condition. And then we use computer software to filter out all the known variants, leaving those variants that are unclear what their significance might be or have never been seen before. And then these have to be individually analysed by clinical scientists. So it isn't a whole genome. You do still get a panel analysis, but the whole genome is sequenced. And what that means is that it is a one-off event, doing a whole genome sequence, and you can come back to it in the future to reanalyze other genes and use that as a research tool as well if you're looking for new genes that cause cystic disease. So whole genome sequencing can be requested, as I said, by clinical geneticists and nephrologists. It is done in the same way as ordinary genetic testing. It is an EDTA sample, but the difference is that it is all done in a single site, which is the Illumina lab in Cambridge. And you do require a particular request form to do that, and something called a record of discussion. And so I'm going to stop the PowerPoint slides, and hopefully this is where it could all go horribly wrong. Bring up, so I'm going to start sharing my screen. So can you see that?
Yes, thank you.
Good. All I can see is Albert's face in my screen. So this is the request form for a whole genome sequence. So first of all, where do you get these forms from? So you can either get them from your local genomic laboratory hub or your local genomics lab. They will have them for you, or you can go onto the NHS England site to get them. So this is the form that you need to fill in for a whole genome sequence, and it's got the usual demographic data at the top. For most of the individuals that you'll be doing PKD testing for, it can just be a single sample. When we're doing whole genome sequencing on children, we usually do trios, which is the child and both parents, because that makes analysis of variants much easier if we have a trio. But it's unlikely with a lot of our adult patients that you're going to have both parents, and so we'll accept just the single case from the patient. Then what you need to do is put in the panel that you're going to do. And this is where that R code comes in. You need to say that you're going to do R195 in the cystic renal panel. If you've got other family members, then you will be putting them in as well. And then you put your own details at the bottom. And if you think it's definitely PKD, then it's very helpful for the lab and analysis to put that in. And then what we really want you to do is put as much clinical information in as possible, because again, that helps with the analysis, particularly when we are looking for some of the perhaps less typical, not PKD1 or PKD2, some of the other genes that might be causing renal cystic disease. You need to tick this box, and I'll discuss what the record of discussion form is in a moment, to say that that's coming with it, or it's not coming with your form, but it's following. And then you need to put the HPO terms on the back, which you can do by ticking. These are the human phenotypic ontology terms, and for renal cystic disease, it will be one of these. Maybe one, it may be several of them, and if you just kind of copy and paste up into this for your proband and anybody else in the family that you're testing. So that's the form that you need to fill in to request a whole genome sequencing, and then the other form, which hopefully will come up. Can you see this form, the record of discussion?
Yes, thank you.
Brilliant. So this is the record of discussion, and this needs to come with the request form for your whole genome sequence. And basically what this is a checklist to make sure that you have covered everything that you need to think about when you're doing genomic testing. The main things are the implications for other members of the family. So with a genetic test, obviously, it's not just the individual, but it's their relatives as well, that it might provide information for. You need to explain a little bit about the uncertainty associated with this testing, because we will and we do find variants of unknown significance where we really do not know what they mean. They may be pathogenic, they may be benign polymorphisms. And so this is not a black and white test. We always store DNA afterwards, and we're storing data, and so those things need to be mentioned as well. And then the other thing that goes along with whole genome sequence testing is this invitation to something called the National Genomic Research Library. So NHS England have decided that they want to invite every single person who has a whole genome sequence into this research arm. And this is allows access by researchers within predominantly the NHS, but also monitored researchers from outside the NHS, to look at the data that is being stored from whole genome sequencing with a view to identify new genes and then potentially new treatments and new ways of managing genetic disease. And so again, on the other side of this record of discussion form, these are the checklist points to go through with individuals to find out whether they would like to participate in this part of it as well. Now, that is not necessary to have your whole genome sequence, but NHS England are keen that we do ask individuals if they would be prepared to participate in that research choice. And then the third page of your record of discussion is to say, have you had that discussion? And if so, what was the patient's choice about allowing their data to be looked at in that way? Patient can sign it themselves. For children, we'll need an adult signature. But we can also take remote consent, particularly in these COVID days. And if you're going to do that, you just need to tick that box, and then you don't need the patient's signature. If they have decided not to participate in the research choice, then NHS England are keen to understand why that is, and so you're asked to put in this box as well. And then you sign the form, and generally what we've been doing is just requesting the blood with a normal request form, and then with the WGS request form and the record of discussion, we have been scanning those and sending them to the lab so that they arrive either at the same time or just after the blood sample. So that is all I'm going to tell you about genetic testing in PKD. Thank you.
Thank you, Jackie. Thank you, Jackie. So I think that we've had quite a few questions come in about funding and all that, but that we can leave that for later.
Yeah.
Great. So our next speaker is Dr. Ragada El-Damanawi, who's a consultant nephrologist at Sheffield, having trained at Cambridge before coming to Sheffield. So she has an interest particularly in pain, in PKD, and has done some work in this area. So I think this is probably a neglected symptom in the patient. So I think I look forward to what you have to say, Ragada.
Brilliant. Thank you very much, Albert. So today I'm going to talk to you a bit about some of the challenges looking at pain in polycystic kidney disease and present sort of a tool that was developed by our group called the APAT, and then some of the data that we basically found from the study using the APAT. So ADPKD related pain is actually quite prevalent in the adult PKD population. Many of us who do clinics with PKD patients will know the debilitating impact of that. But it's quite interesting in that it's quite an early phenomena, and it occurs sometimes even before the kidney function or kidney size has increased significantly. And it's often a presenting symptom. Now, pain is very complex in PKD. We actually don't understand it very well. And even within the same patient, you can get a variety of pain spectrums. And whenever we consider pain, we really have to consider it in the context of, the individual. And, this obviously impacts their experience and perception of the pain. So whenever we think about pain in polycystic kidney disease, so you can think about the acute pain episodes, and these are triggered by a specific event. In theory, once this event is treated, the pain should stop. This is not always the case. Sometimes we think that there are aberrant nerve pathways that become stimulated and continue to be stimulated even after this reversible cause has gone away. And that means that patients can then develop chronic pain after an acute event. When we think about chronic pain, you can think about pain that's related to ADPKD either directly, which you would expect if you've got an enlarging polycystic kidney, or indirectly. So these are pains that the patients wouldn't have if they didn't have polycystic kidneys, but don't come directly from the kidneys. And then finally, and this is the group that sometimes gets neglected in patients with PKD, and this is pain that's not related to their PKD, and this is kind of the consideration of other differentials that could be contributing to pain. Oh, let's try that. So the important thing about pain is that, as I've said, it occurs early, but actually it's hugely underestimated. And this is just a qualitative study where they were looking at the perception of healthcare professionals and nephrologists versus, patients with lived experience of ADPKD. And even patients who had CKD stage 1 and 2, so quite early disease, 88% of them had symptoms, the commonest being pain and fatigue, which actually impacted quite significantly on their lives. But when healthcare professionals were asked, actually, most of them thought that either patients had no symptoms, very mild symptoms, and definitely not symptoms that would sort of impact on quality of life. Perhaps the biggest observational study which looked at pain in PKD was a cross-sectional study of over 1,000 patients who enrolled into the HALT PKD study. If you remember, this is was the blood pressure control using inhibition of renin-angiotensin system in patients with ADPKD. And they completed a questionnaire at baseline. Again, over 50% had back pain, just over a quarter had abdominal pain chronically, and pain was prevalent again in early disease. But the interesting thing was that it wasn't actually correlated with kidney size until the kidneys got quite big. It's also interesting to note that a lot of patients were taking non-prescribed over-the-counter medications, and this is often not captured in our consultations. We know that pain is important to patients, and I'm not going to spend too much time on this, but you'll be aware of initiatives like the Song PKD initiative and the James Lind Alliance, which have highlighted how important it is to measure pain as a clinical endpoint or an outcome in trials, but also to do more work in terms of trying to understand and manage it better. So how do we manage it at the moment? Well, often patients go through a stepwise kind of progression. So we start with the sort of non-invasive, non-pharmacological therapies, then they progress to more systemic therapies, often working their way through the WHO analgesic kind of ladder. Then, and more recently, there's been more of a focus on disease-modifying therapies, and there was a paper looking at the impact of Tolvaptan in terms of reducing acute kidney pain events. There may also be a role for things like octreotide. And then finally, and this is for sort of intractable pain, the more invasive kind of surgical options are sort of almost thought of as a last resort, really. Now, despite all of this, actually more than 40% of patients do not get adequate pain relief and continue to be pretty debilitated despite working through this pathway. So why do we manage pain so badly? Well, there's currently very limited evidence. We don't have enough in terms of even observational data that really kind of looks at what the pain patterns and characteristics are in our cohort. In our cohort of ADPKD patients, which means it's really difficult to target therapies to the underlying mechanisms. The other thing is that often the treatments that we use are generic and extrapolated from kind of generic pain studies rather than disease specific for ADPKD. In terms of interventional pain studies, often, and really more recently, we've got better at this. We've kind of failed to use sort of pain as a patient-reported outcome. But as I say, this is getting better. And what trials are done tend to be quite small and non-randomized anyway. And this is the most important thing. We don't have a standardized and validated ADPKD pain-specific tool. This means that we can't really pool data across studies. It means that we can't compare interventions. And it makes it quite difficult because if you can't measure pain, how can you address it? So the ADPKD working group was formulated, and it consists of pain experts, patients, members of the patient-led research hub, and ADPKD experts as well. And they came together. Now, the first step is that the objective was to try and improve our understanding of pain in PKD, and to do this through the development of an ADPKD specific tool. Now, these are the impact consensus domains. So the impact consensus group came up with a set of 6 domains which should be considered whenever you are considering an interventional or a pain trial, essentially. Now, as you would expect, so you should include a domain on pain and some of its characteristics, but also the emotional and physical impact of it, which makes sense. Whenever an intervention is delivered, you need to have a measure of improvement, also the symptoms and side effects associated with it. And this is quite important, so the patient disposition, so looking at why certain patients would have withdrawn or declined to participate and how this would have impact on your clinical findings. The first step is that we conducted a literature review looking at all the observational and clinical trials which had included pain assessment in ADPKD patients. And we screened 728 studies and ended up with 34 studies which were included in the qualitative synthesis. It won't surprise you that over 34 studies, there were 29 different tools that were being used to measure pain. And they ranged from, just asking about pain frequency to intensity, to using generic tools, to attempting to use more ADPKD specific questions. Now, most of these studies were actually interventional, and what we did for each study is we evaluated what aspects of the impact domains they had included. Unsurprisingly, the interventional studies focused on the intensity of pain, but also on measures of improvement and adverse events, whereas the observational studies, as expected, included information about or evaluations of pain intensity, some of the temporal aspects, so the frequency and incidence, interference and analgesic use, but they didn't really focus on the quality of the pain. So together as a group, we defined the main themes that everybody felt was important to be included, and this was a very much a patient-led project. And then with the expertise from our pain experts, we basically looked at which of the validated pre-existing questionnaires could be used and incorporated in order to answer these questions or evaluate these domains. And that led to the development of the ADPKD pain assessment tool, or APAT for short. It went through several iterations to make sure that it was easy to do and to understand. Now, I don't have a copy of this, just to kind of a copy of the APAT, just to kind of, because there isn't enough really time. But if anybody's interested, there is a publication with the results and a copy of the APAT and CKJ, which you can look at. So the APAT was then administered to patients who were taking part in the DRINK study. And this was a randomized feasibility study where patients with an eGFR of above 20 were randomized either to high water intake or normal water intake. And although we administered the questionnaire to all participants at the beginning and end of the study, we combined both groups because when we analysed it, there wasn't any differences between the groups. So the questionnaire was administered via a smartphone app, and for those that didn't have apps or didn't have smartphones, it could be done on paper. But this was fantastic because it meant that it was more efficient in terms of data collection and extraction. In terms of the results, so 93% of patients submitted 129 responses. So that's an average of 3 questionnaires per participant. 88% of them were done via the smartphone, 50% were complete. And when you look at the population, so 47 years of age, but actually in terms of risk factors for progression, so more than 2/3 had hypertension, enlarged kidney size, evidence of hematuria, so a high risk with reasonably preserved kidney function. In terms of pain severity, so participants were asked about the worst, least and average pain severity over the last couple of weeks and the pain right now. So if we focus on the average pain severity, so at least nearly 45% had mild to moderate pain. And pain severity was predicted by sort of female sex, having more advanced kidney failure and hypertension. Interestingly, not by enlarged kidney size. When we looked at the site of pain, so as you would expect, lower abdomen, a lot of lumbosacral discomfort, pain in the knees, which is unsurprising, but also in the back of the head and neck. So quite widespread, I would say. In terms of pain quality, patients were asked to describe their pain using 21 descriptors, which were divided into either continuous, intermittent, neuropathic, or effective pain descriptors. So lots of people used continuous descriptors, so in particular an achy type of pain. There was around 20% used kind of intermittent descriptors, but there wasn't much in the way of neuropathic descriptions of the pain. Pain frequency, so at least 81% of patients had had 2 to 3 pain episodes over the preceding week, so quite frequent. And then in terms of the analgesic burden, this was quantified using something called the medication quantification score, which looks at the dose and the kind of burden of the analgesia that's being used. And really, at least about 30% were on some form of analgesia. And it's interesting because sort of at least 20% were using neuropathic pain analgesics. And if you kind of look at the previous slide, it doesn't seem like neuropathic pain is a particularly prominent factor here. In terms of analgesic burden, so this was increased in females and pain severity. So that's actually consistent with previous studies. And this is quite interesting. So in terms of the EQ5D, we divided patients in terms of whether they didn't have pain or they did have pain. And you can see that the patients that did have pain were more likely to report problems with sort of mobility, self-care, activities of daily living, and their mood. Patients were also asked to self-rate health scores using the visual analog score, which is between 0 and 100. And you can see that those with CKD stage 4 had much lower self-reported health scores compared to those with CKD 1, 2, and 3. And this effect was actually more pronounced in males, interestingly. Now, what predicts your self-reported health status score? Well, lower scores are associated with advanced CKD stage and pain severity. That's to be expected. But it was quite interesting that patients who had hypertension had higher self-reported health scores. And it's not entirely clear as to whether this was because they were managing their own blood pressure and felt a bit more empowered. So pain in PKD was prevalent. It was frequently occurring and associated with a significant analgesic burden. Markers of disease severity predicted pain severity, but not enlarged kidney size, and that was consistent with previous bigger studies to the whole PKD data, which was quite reassuring. And as expected, pain was associated with quite a significant psychological and physical burden for patients. Now, in terms of next steps, so EASE PKD has been awarded a NIHR RFPB fund, and this is a prospective observational study of 600 ADPKD patients where we'll be using the APAT, and patients will be filling that out on a regular basis, and that will be linked with routine data sets to look at sort of patterns and predictors of pain in ADPKD, so linked with sort of demographic and clinical data. Right, so lots of people to thank, including obviously the PKD charity and Tess and all the patients who without which really we couldn't have developed this patient-led project, and also the RGTD clinic in Cambridge and Dr. Hemistra, who put up with me for 4.5 years. So that's me.
Thanks, Ragda. Lots of interesting data to discuss. Perhaps we could deal with some questions in the Q&A. We're just running a little bit over time, but I don't want to rush Tess because looking forward to what she has to say. So it's a pleasure to have Tess Harris to finish this this session today. So Tess is well known to the PKD community, both among patients and medics, and she is currently CEO of the PKD charity and also president of PKD International. So I've asked Tess to kind of address a question that I think we should all consider. What do you think should be standard care for all PKD patients wherever you are in the UK? So Tess, over to you.
Thank you. Thank you, Albert, and hello everybody. And thank you to the UKKA and Albert for inviting me to speak today. So as Albert said, I'm Tess Harris. I'm CEO of the PKD charity. I'm also an ADPKD patient. In fact, I was diagnosed in the Sheffield Northern General Hospital more years ago than I can recall. I don't have any disclosures. So I've been asked to give this patient perspective on what should be standard care for ADPKD patients in the UK. I thought you probably would gather that I've got some ideas, but I thought as a benchmark, I start looking at what currently is standard care for ADPKD. So that was my big question. What is standard care for ADPKD currently for patients in the UK? And I did some searching and concluded, probably unsurprisingly, that it's a collection of formal and sometimes informal guidelines, recommendations, best practices, scattered around the web mostly. So if you start with a search of NICE, which would be the most obvious place to go, and type in autosomal dominant polycystic kidney disease, you will find 4 references, just 4. The first one is for Tolvaptan for the recommendation in 2015, which we discussed earlier. And then 2 rather interesting pathways relating to kidneys. We've got one called kidney conditions, which actually leads back to Tolvaptan. And it also leads to the other interactive pathway, which is chronic kidney disease, which is a guideline. And then there was another guidance or pathway on cardiovascular disease prevention. Whoops, sorry about that. And I actually couldn't find any reference to ADPKD in that particular pathway. So I just had a quick look at the CKD guidance, which was issued in 2014. It has been updated just now, so I expect this pathway will be updated at some point soon. And I found the references to ADPKD there. First, in the top one on the left here, you can see where it says person with possible chronic kidney disease. And in there, it's actually a reference to patients with a family history or hereditary kidney disease. And then the actual reference to ADPKD is in the assessment and monitoring part of the pathway, where it's referenced directly in renal ultrasound. But apart from that, nowhere else in this pathway. And if you start working your way down this pathway, you end up in a sort of confusing labyrinth of other pathways, which really wasn't very helpful at all. I thought I'd look at outside CKD to see what guidance is out there for other aspects of ADPKD, hypertension being most important. And recently, NICE published in 2019 their guideline. No reference to ADPKD in that. Of course, their guidelines are written on the best possible evidence, so they obviously didn't even consider HALT PKD as evidential enough. And then more recently, there's been a guideline published on pain, and this was a rather curious guideline because it was described as primary chronic pain. And when I contacted them to provide our input, they said ADPKD was not considered primary, and so it wouldn't be included in the guideline. We did put a contribution in anyway. When they published it, they added the word secondary into the guideline. But nonetheless, there's nothing there really of great relevance or usefulness to ADPKD. And as you've seen from Ragda's slides, that wonderful strategy or a pathway step ladder approach is certainly not included. Genetic testing, we've heard from Jackie about the availability of genomic testing for ADPKD, and is of course included in the directory. But the guidance, unlike Jackie's slide where she showed how Sheffield approaches genetic testing, the guidance I thought was a little bit vague in that it just says it could be offered if it's helpful for management of the condition. I guess it's open to interpretation what management is. As we've seen, it could be more or less useful in eligibility for Tolvaptan. Going back even further in time, I fell across the laparoscopic deroofing of cysts and the laparoscopic nephrectomy. Not really helpful today, and of course nothing mentioned on ADPKD. And the renal replacement therapy, which was only published in 2018, had nothing on ADPKD, which is a bit of a shame because the patient, sorry about that, I don't know why my computer's got a mind of its own this afternoon. As we know, a question that many people ask is, will I have to have my kidneys out before transplant? There seems to be varying opinions from surgeons. Some say they'll squeeze them in, some say they have to remove them. There's no room. And then there's the consideration of whether people with very big cystic kidneys can actually have PD. More recently, we know from the ISPD guidelines that it's not contraindicated, but that was too late, of course, for this guideline. And then, of course, we have an extremely important guideline, which doesn't say anywhere near nice, which is monitoring children and young people with risk of ADPKD, which is available if you hunt for it on the UKKA website, published 2018. And then there's all the other aspects of ADPKD. I did take a quick look at urinary tract infections, but it really was totally, well, it was virtually irrelevant. And of course, the other aspects of care are not really, don't really include ADPKD within them. So that's sort of a quick whirlwind tour through standard of care. So it's probably not surprising that it's confusing for healthcare professionals, as well as it's confusing for patients. So I thought I'd just sort of elaborate that a bit from a patient perspective and pick out a few comments from a large survey we did a few years ago of several hundred patients and carers, and grouped some of the comments in themes. And these are recurring themes that continue today. We get comments like this regularly on our Facebook groups and when people phone us on the helpline. So for diagnosis, in this case, this patient was experiencing a GP as a bit of a gatekeeper. And many patients do talk about their GPs being somewhat ignorant about ADPKD. In terms of progression, we still, amazingly, people are being told it's a waiting game and feeling that real care seems to kick in when your EGFR gets to about 20. In terms of interventions, and apart from Tolvaptan, which we've seen how much uptake there is of that at the moment, the comments here about needing better process to treat infections. Every day on our a member of our community is posting about an infection or a suspected infection and doesn't know what to do, can't see the GP, rings 111, and often goes to A&E because they just don't know how to treat it. Or GPs or other doctors don't know how to treat it, and of course they may not need to go to A&E at all, and it's a waste of everybody's time and money, including the patients. In terms of ongoing management, as I and other PKD patients could attest, the annual appointment, blood pressure, quick chat, see you in a year. But most people would say they would like to know more info about diet and treatment and support. And many, of course, go to the internet as a result. And then in follow-up care, somebody here feeling they're very much largely on their own in managing their condition. Someone had just been diagnosed, came out of hospital and didn't know what to do about pain management or diet, etc. And then support, with doctors tending to treat symptoms and not look at the person, advised to lose weight, despite having big kidneys and liver and not feeling at all supported. So that's sort of a view from the looking at it in a way of healthcare and then patients. And this is a chart that shows the outcome of our recent top 10 priority setting partnership, where we identified in consensus the top 10 research priorities for ADPKD patients in the UK. And this was agreed by patients, carers and healthcare professionals. And it's probably therefore no surprise that number 3 in the research top 10 was research into how should care be organised to improve outcomes. So this is really identified now as an important topic. So if anybody out there's got any ideas, I apologise for my zipping through the slides here. It's like my mouse has got is doing its own thing. If anybody's got any ideas, please come forward with them. So what should standard care be like? In Europe, we had a stab at it by developing what we call the ADPKD patient route map. And this was published through PKD International. and we were supported by members of the European ADPKD Forum, which Albert and myself are members, and other healthcare clinicians around Europe, and patients and carers. And so this is a way, it's an interactive document which describes the care and support patients and families affected by ADPKD should expect from any health service. So it's mapped across the whole of the lifetime of the patient and care, and in particular shows sort of ongoing care and support that patients should expect. The effects and complications of ADPKD, not just the kidney, of course, but the extrarenal, the liver, the brain, pain, as discussed earlier, well-being, genetics, and so on. It's referenced throughout to any existing guidelines and scientific papers. It's not obviously a guideline or a clinical pathway, but it's a sort of it's described as a route map to help both patients and healthcare professionals to navigate their way through care. And then another approach in 2016, Albert very nicely suggested in a paper in 2016, a recommended MDT step pathway for managing patients, which took the form of topics that might be discussed at a sequence of visits or appointments, starting with the diagnosis. But again, it's not just a straightforward bloods and blood pressure appointment, but it's considering from the start whether to do any imaging, providing good patient information, reference to patient support, a bit of dietary advice, which is the #1 topic for most patients with ADPKD, as well as the important treatments such as hypertension. And then looking beyond that through counselling, prognosis, and being conscious also of being able to refer on to other specialties for those who might be prone to polycystic liver, those with family history of aneurysms. Ragada's already pointed out how under-recognised pain is, but we know that pain care is a bit haphazard, and it's a bit of a postcode lottery if you want to get a referral to a pain clinic, and then family planning, children, and all this wrapped into a shared care or annual follow-up care pathway care plan. So in conclusion, what can we look for perhaps in the future? Well, I'm pleased to say that there is a KDIGO ADPKD global guideline in production. We're expecting it around about 2030, 2023. But to me, the big challenge is, how do we get this into NICE? As you've seen, not all the guidance or recommendations are in NICE. They're scattered around. And I see that as an interesting challenge for us. But I'd like to leave you with some key messages. First of all, remember that ADPKD is more than a kidney disease. I'd like you to go beyond the symptoms and look at treating the person in front of you who's got those anxieties and pains and niggles and concerns about their family and their future. Look at them holistically and integrated. Would a route map or similar be helpful at this stage, or something similar when the guidelines are published? Could that be something that we could challenge and we champion and take up? And then finally, do remember, PKD Charity is available to offer support, as we call it, outside the clinic. We have trained befrienders, we have a listening ear via a helpline, and a fabulous community of patients, family members who provide tremendous peer support and lived experience on a 24/7 basis to anyone who comes to us. I'd like to thank you. Obviously, I'd like to thank all the patients and everybody in our community. This is where you can find me out and about on the internet. That's the end of my talk.
Great, thank you, Tess. That was really nice. And can I just invite all the panel members back if they're still with us? I think we've not lost too many people. So some people have got not run off to catch buses or trains or whatever. And we have quite a few questions. So for the sake of time, I guess, let me just try to summarize some of the questions and just put them to the panel and to answer. So I guess first off, Jiehan, so I think 2 questions about Tolvaptan. So is there a better way than using GFR to monitor efficacy? And a kind of related question is that I'm surprised that your osmolality is quite high if they were drinking 7 liters a day. So 2 questions about Tolvaptan. Would you like to try to answer that?
Yeah, so in terms of monitoring Tolvaptan efficacy, I guess it depends on how you're defining efficacy and what population you're looking at. So in a cohort like what we've got in our clinic, where pretty much all our patients are already selected for eGFR decline, I think there isn't obviously a better way to monitor it, because your whole intention in treating is to slow eGFR decline. So the thing to look at is eGFR, the most direct observation. I do think, however, that in different populations, there may be space for different tools, although I'm not sure if there are any concerted efforts to utilize these. For instance, there's some suggestion that Tolvaptan may be useful in renal pain, and it's obviously an important symptom for many people. And if you were using it to try and treat renal pain, which isn't currently on the NICE approval, then obviously you'd want something other than eGFR to help you monitor that. And in the future, I think this is speculative, but as described by Jackie, I think the future of treatment is probably modalities where you're trying to treat the disease before you've got to visible and growing cysts, and certainly before you reach decline eGFR. So in that population, you won't have eGFR changes, and you might need to use something like MRI-TKV or perhaps some alternative biomarker of cyst proliferation to study. But all this is very much in the experimental and speculative phases, and I don't think there are concerted efforts in routine clinical use to provide that kind of monitoring at the moment.
Okay.
With regard to the osmolality and volumes, that's an interesting observation. It's not something I have thought about myself, but I think I will go back to our data and have a look at how the osmolalities match up to how the osmolalities match up to the urine volumes, which might give some indication about this relationship. I don't know if anyone has anything to add to this.
I think one thing to comment about certainly our practice is that we haven't accounted for salt intake. So we haven't kind of corrected for salt intake. So that would also affect the number of osmoles taken in, and therefore also the obligate urine excretion, if you like. Yeah. So anyway, but thanks for the question. So we'll go back and look at that. So I think lots of questions for Jackie on testing. So I think predominantly around cost, who pays, secondly about turnaround time, there's very long turnaround time, and being refused treatment. I've tried to get funding, but they've stopped me in the past. So can you reassure the audience that they can now freely get testing without worrying about payment? And you'll get it quickly as well, because that was the other thing. It takes ages.
So yes, you can get testing without payment. So the payment for all genetic tests has now been removed from trusts and is paid centrally. So you will not receive a bill. There's obviously an issue then for NHS England about appropriate requesting of genetic tests, because there is the risk that they have so many requests that they run out of money. So I think it is going to be monitored, it is going to be audited to ensure appropriate requesting, but you do not need to pay. Time, so time taken for genetic testing, it's not so much the test, it is the analysis time. And so it is partly determined by how many variants are found and how difficult they are to work out what's going on. But our experience in clinical genetics with whole genome sequencing that we've been doing is it's been taking about 3 to 4 months, which is better than a year, but could be better. So it may speed up a bit, but I think, you know, I would work on about 3 to 4 months at the moment. And then there was a question in the chat I noticed also about the forms, and if you were doing a trio, which is what you might be having to do if you're doing pediatric testing, do you have to fill in 3 ROD forms? So you did, but you do not have to anymore after a huge amount of complaints. The form has been changed, so you just need to make sure that you've got the latest version of the ROD form. And if you've got that latest version, for a start, it self-populates. So once you put your demographic data in, it self-populates further through the form. But no, you can use one form for both child and both parents, and you don't need to fill in 3.
Great. Okay. So get testing, get requesting. If it's coming late, then contact Jackie.
Thank you.
Anytime. So questions about pain. So quite a few questions about pain for Ragda. I think a question about, can we take part in your EASE PKD study from other centers? And then some questions about options for treatment. So would you like to answer the first question about, can other centers take part in your study?
Yep, absolutely. So I guess the aim of the study is that it's as pragmatic as possible, so you can actually self-refer and self-enroll in the study, and providing you consent for sort of data linkage so that we can get some of the other data around sort of kidney size and kidney function and things, which is usually quite helpful. That's absolutely fine. You don't, you know, we're looking for 600 patients across the country. It doesn't necessarily need to be associated with a particular renal unit.
Okay. So they can contact you if they're interested. Yeah,
yes.
Each centers. Okay, so contact Ragda directly.
Yeah.
There are some questions about sort of specific modalities for treating pain. So what about the experience about using renal denervation? Can you comment on that? And also, what is your preferred treatment option for continuous throbbing pain? So could you like to quick answers to those questions?
Yeah, so I mean, I think renal denervation is again sort of part of the surgical invasive last resort. There was a study which was published, and I think there is an element of recurrence as well. So it's not a forever kind of fix or treatment. So I would say if only really if you've gone down the route of lots of other treatments and it's not worked, there's not a huge amount of evidence supporting it. So I think not an easy option, I don't think. And certainly not.
There are some case reports, I believe, but I don't think it's been formally tried in a trial. So, but thank you. So any specific questions about that can be answered by Ragda directly or on the chat or after the call. Questions for Tess. So Tess, a comment that basically what you shared about the patient survey, very similar to what we've seen in the US. So clearly the experience is universal and not specific to the UK or the NHS.
Yes, indeed. And it mirrors what the European patient associations are finding as well.
And I think yeah, that's mainly sort of the comment really about Tess for Tess. Yeah.
Yeah. I think I inadvertently clicked Kevin's second question.
Answered Kevin's second question. Okay, great. Yeah. I think there's a question about new drugs. So someone was asking about could we combine metformin with tolvaptan? And currently the answer is no, but there is a phase 2 study that's come out in Kidney International, so which is more of a safety study, but the exploratory data on efficacy was inconclusive. So there will be a phase 3 trial starting soon. So there may be an opportunity to take part in that within the UK if that's approved. All right. So the role metformin is still unclear for disease progression. Question about estrogen, and a question about any new drugs around the corner, or is it just Tolvaptan? So, I mean, for the sake of time, let me just say that the role of estrogen in liver cysts seems quite strong, although intervening by doing anti-estrogen therapies has not been tried. But paradoxically, the role of estrogen in renal cysts is the opposite, because we know that males have more severe disease than females. So there's a paradox there. So estrogen perhaps for the liver, but perhaps not for kidney cysts. And in terms of new drugs around the corner, I'm afraid that with the termination of the Sanofi stage trial, it does look like Tolvaptan is it for now. I think there's obviously a trial of bardoxolone, which will report in a couple of years. There is a new Vaptan that's going to be tried called Lixivaptan, probably starting the end of this year. But again, that's going to work similarly to Tolvaptan, perhaps with a better safety signal for the liver, we hope. So I think we probably need to learn how to use Tolvaptan better. And so I think, it's something that we should try to understand, to try to use it better across the UK, because I think it's going to be at least a couple more years before there's something else to offer. I think some other sort of questions, more sort of technical questions about pain, and also requesting genetic tests, but I think probably that's can be answered offline. Okay, I think that's it actually. So can I thank the speakers for their contributions today? It was a really excellent session. Sarah for her help technically. And I think if you had any further questions for any of the speakers, please feel free to approach each one directly. And I hope that most of the questions we've managed to answer. So Sarah, would you like to say a few words about the CPD?
Thank you, Robert. Yes. So we've got 2 CPD credits for this webinar from the ICP, and you'll be receiving a link to a feedback form in the next couple of days, and you'll be able to request a certificate at the end of that feedback form. Great.
Okay, so thank you all for attending and for your very active participation. I hope it was helpful, and I hope that we can improve whatever we're doing for patients, wherever you are, whether in the UK or elsewhere. And thank you all for attending. Have a great summer, and we'll see you soon. Bye.